Hi, my name is Captain Schellebarger, and I'm a student at the United States Army Graduate Program in Anesthesia Nursing, and this is a presentation on the drug Labetalol. Labetalol is formulated for IV injection with a concentration of 5 milligrams per milliliter. It comes in a unit dose or multi-dose vial. Labetalol is classified as a beta-adrenergic antagonist. It competitively inhibits beta-1 and 2 adrenergic receptors, and weakly inhibits alpha-1 receptors. The ratio of binding beta receptors to alpha receptors is 7:1. It is primarily used to treat hypertension and tachycardia intraoperatively. Adrenergic receptors are transmembrane receptors that are coupled to an intracellular G protein. These G proteins have three subunits, an alpha, beta, and gamma subunit. These protein receptors are termed G-coupled protein receptors. The sympathetic nervous system's effects are mediated via two different types of G-coupled protein receptors, alpha and beta receptors. These two classes are further broken down into alpha-1 and alpha-2, and beta-1 and beta-2. G-coupled protein receptors do not cause intracellular events by themselves, but are linked to intracellular primary messengers, which lead to a cascade of events and production of second messengers. Beta-1 and beta-2 receptors are linked with the enzyme adenylate cyclase, a primary intracellular messenger. G-coupled protein receptors that are linked to adenylate cyclase are termed GS-coupled protein receptors. Binding of a ligand to a GS transmembrane receptor activates the intracellular G protein. The alpha subunit dissociates from the beta and gamma subunit and activates the intracellular enzyme adenylate cyclase. Adenylate cyclase facilitates the conversion of adenosine triphosphate, or ATP, into cyclic adenosine monophosphate, or cyclic AMP. Cyclic AMP acts as a second messenger to disinhibit protein kinase A, which activates intracellular processes through phosphorylation. Alpha-1 receptors are linked to the primary messenger phospholipase C, a transmembrane enzyme. G-coupled protein receptors that are linked to this enzyme are termed GQ-coupled protein receptors. Ligand binding to a GQ-coupled protein receptor activates the intracellular G protein. The alpha subunit dissociates from the beta and gamma subunits and activates phospholipase C. Phospholipase C is an enzyme that cleaves a membrane phospholipid into two molecules, inositol 1,4,5-triphosphate, or IP3, and diacylglycerol, or DAG. IP3 acts on the endoplasmic reticulum and causes the release of stored calcium into the intracellular space. DAG activates protein kinase C, which phosphorylates many intracellular processes. Adrenergic receptors are found throughout the body, but the preponderance of beta-1 receptors are found on the heart on the myocardium. Beta-2 receptors are primarily found on the respiratory, uterine, and vascular smooth muscle, and alpha-1 receptors are found on the vascular smooth muscle. Beta-1 activation in the heart under normal conditions causes protein kinase A to phosphorylate ion channels, thereby speeding depolarization and repolarization of the heart, increasing heart rate, contractility, and cardiac output. When a patient is given labetalol, it competitively antagonizes these beta-1 receptors, which leads to a decrease in heart rate and contractility. Beta-2 activation on the respiratory smooth muscle stimulates the activation of protein kinase A. Protein kinase A phosphorylates myosin light chain kinase, which inhibits the phosphorylation of respiratory smooth muscle, causing bronchial dilation. When a patient is given labetalol, it competitively antagonizes these beta-2 receptors, allowing myosin light chain kinase to work on the smooth muscle and promoting bronchial constriction. Alpha-1 activation on the vascular smooth muscle causes the release of intracellular calcium from the endoplasmic reticulum. When calcium is released, it binds to the intracellular protein calmodulin, which forms a calcium-calmodulin complex. This complex then activates myosin light chain kinase, which phosphorylates myosin and enables its interaction with actin, stimulating vascular smooth muscle contraction and raising blood pressure. When a patient is given labetalol, it competitively inhibits these alpha-1 receptors, leading to a decrease in calcium release, promoting vascular smooth muscle dilation. Labetalol is typically administered 5 to 10 milligrams at a time in 5-minute intervals until the desired blood pressure has been reached. Labetalol can also be administered as an infusion. A mixture of 200 milligrams and 250 milliliters D5W is titrated to a desired response at a rate of 10 to 180 milligrams an hour. Prolonged infusions of labetalol are not recommended. Onset for IV labetalol is typically 2 to 5 minutes, but it can take up to several minutes. Peak effects are typically reached within 5 minutes. Labetalol's elimination half-life, or its T1F beta, is 5.5 hours. This long elimination half-life accounts for its prolonged clinical effect. Total body elimination of a single dose of labetalol typically occurs within 22 to 27 hours. Labetalol is primarily metabolized in the liver through conjugation to glucuronide metabolites and excreted by the kidney and in the stool. Impaired hepatic or renal function does not significantly affect the metabolism of labetalol. Labetalol is commonly used as an antihypertensive during the perioperative period. The alpha-1 blockade decreases vascular resistance and drops blood pressure. This normally triggers the baroreceptor reflex to increase heart rate and contractility. However, labetalol's blockade of beta-1 receptors on the heart inhibits this reflex. Thus, labetalol is used to decrease blood pressure without causing a reflex tachycardia. Because reflex tachycardia increases the cardiac workload and myocardial oxygen demand, labetalol is an excellent choice to treat intraoperative hypertension in hypertensive patients with coronary artery disease. Labetalol's antagonism of alpha-1 receptors will decrease blood pressure and should be avoided in patients with severe hypotension. Labetalol's antagonism of beta-1 receptors may decrease heart rate and contractility and should be avoided in patients with significant cardiac failure, second or third degree heart blocks, cardiac shock, or severe bradycardia. Labetalol's antagonism of beta-2 receptors can promote bronchial smooth muscle constriction, increasing airway resistance. It should be avoided in patients with COPD or reactive airway disease.